Well, greetings everyone, and welcome to the ECG case for the week of January 19th, 2015. This week's case is going to be just a little bit longer than before, and as I said, when we switched over to this new website, it was going to give us the availability and option of expanding things a little bit, so we're going to go a little bit beyond the ECG case. All right, so there's actually two cases, both of which were sent by Dr. Lakshay Chanana, who's working in Hyderabad, India. I actually got a chance to meet Lakshay this past fall when he came to Baltimore for a course that we do on teaching emergency physicians how to teach. And he's a really, really nice guy. He sent me some great cases. And I also want to send props out to him because on, January 17th, which means just 2 days prior to the release of this video, Lakshay is going to be getting married. And here's a photo that he sent of him and his lovely bride. Hopefully, Lakshay is not actually listening to this or watching this video on Monday the 19th as we release it because, if you are, we need to have a little talk. You should be doing some other fun stuff. So hopefully both of you are having a great time on your honeymoon, wherever that may be. Anyway, let's go on to the case. This is a patient that he saw while he was working in Hyderabad. It was a 25-year-old man who presented to the emergency department complaining of left arm pain and some upper back pain. So that's certainly not really concerning. This is only a 25-year-old patient. So that certainly ratchets down the level of acuity in your differential, and you probably start thinking about some of the lesser dangerous type of things typically. And anyway, a little bit more history here. This guy had some mild epigastric pain. He had several episodes of vomiting. In terms of cardiac risk, not much. He occasionally smokes. And there's no clear, obvious reason for the symptoms that he's experiencing. So we'll move forward in terms of the physical exam. His vital signs are not awful. He looks a little bit sick, and he's pretty uncomfortable. His heart rate's 100, but his blood pressure's okay. His pulse ox is okay. He is a little tachypnic. So we've got a couple of abnormal vital signs there that we should at least pay attention to. He does have what appears to be some musculoskeletal issues. He's got some thoracic spine tenderness and also some tenderness of his left arm. It's not necessarily completely reproducible, but he's got a little bit of pain and tenderness there. His skin is normal, so zoster is certainly a consideration, but maybe it drops down a little bit because he has no signs of erythema or vesicles or anything else like that. And so we'll stop here for just a second and ask, what do you think the differential in a patient like this is? Now, he's only 25 years old, so we're not jumping up and thinking about necessarily some awful things. He does have some musculoskeletal type of abnormalities there. But if this is just muscular in nature, why is he vomiting? Why does he have this epigastric pain? Why is he vomiting? That's not really typical part of musculoskeletal pain. And then on the other hand, if you take the epigastric pain and the vomiting together, well, maybe he's got some type of intra-abdominal problem, pancreatitis, gastritis, whatever. But if that's the case, why does he have this arm pain and this soreness on his back? Maybe we can explain the back with pancreatitis, but why in the world would he be having this arm pain? So things aren't really lining up into a simple differential. So as I look through this history, of course, as an emergency physician, we think about the worst case scenario first, and one of the worst case scenarios would be necrotizing fasciitis. That's something that we see not infrequently, and a lot of the patients with necrotizing fasciitis look pretty sick. Their vitals are a bit off initially, and they just have a sense of pain that doesn't really make sense, pain in an extremity, and then they're vomiting also, or they're diaphoretic, and you're just trying to figure out how in the world does the vomiting or diaphoresis match up with the muscular pain. There's something that's just not right. So that's something that I'm thinking about. And then aortic dissection. Whenever somebody has pain in the torso that's not adding up, you've always got to think about aortic dissection as well. So next question, what do you want to do for this patient? Well, here's a hint. This is an ECG video series, right? So, okay, let's get a 12-lead EKG. And of course, you might want to get some other lab tests, give the patient some IV fluids and Zofran, but we're going to get an ECG. And I think it's completely reasonable in general that if somebody has torso pain plus vomiting, and it's not clearly just GI in nature, I mean, if you have a clear-cut diagnosis, fine, but if you don't have a clear-cut diagnosis, especially with that vomiting of uncertain cause, go ahead and get an ECG. We've said it a million times before, what is the ECG? It's nothing more than a piece of paper and ink. Just a piece of paper, and yet this can give you some helpful information. So we go ahead and we get the 12-lead ECG. There's something abnormal here. There's a few things abnormal here. In a 25-year-old guy, there's certainly a significant amount of ST segment elevation in the precordial leads. Just about all of them have some degree of ST segment elevation. But, he's only 25. A 25-year-old with ST segment elevation, I might be thinking about pericarditis, maybe myocarditis if we're thinking about really terrible things, or maybe this is just early repolarization. He does have some torso pain, and so maybe I'm leaning a little bit away from early repolarization and more towards something like pericarditis. Are there any things that support pericarditis here? Well, the guy does have some PR elevation in AVR, and some of you, I'm sure, have read literature indicating that PR elevation in AVR points towards pericarditis. And you know what? If you look carefully, maybe there's a little bit of PR depression in more than just one or two leads. Maybe there's a little PR downsloping there, maybe a little bit there, maybe a little bit there also. You can imagine some PR depression. An interesting thing about medicine is you can always imagine whatever it is that you want if you've already come to a conclusion about the diagnosis. So just be careful about that. And in general, on the ECG or any other visual diagnosis thing that we talk about, you never want to have to imagine type of finding. So you know what? That's pretty subtle PR depression. And for those people that have followed the previous ECG site, you know that PR elevation in AVR is really, really not supported by any good literature. So let's get rid of that. On the other hand, there are some definite concerns on this 12-lead ECG. There is, I'm not happy about the morphology of the beginning part of the T wave. A normal T wave should be nice and concave upwards, and you notice how nice and concave upwards that is. But whenever you see the initial part of the T wave instead looking really straight and then coming down, and that initial part is very straight, that should make you worry about acute cardiac ischemia or early ischemia. And there are some T waves here that have that appearance. If you look at lead 1, taking a look in lead AVL and also taking a look in lead V4, you've got some real straightening on the initial part of the T wave. And then also we've talked about this concept of this RT phenomenon, or RT segment, where when you have the R wave coming down and then it shoots right off into the T wave instead of coming down and then nice concave upwards. When that R wave comes down and it shoots right off into the T wave, as you see right up there, well, that ought to make you concerned also about true MI and not just plain old pericarditis. And then add on top of that something else that we've talked about before, and there's ST segment depression in leads 3 and in AVF. And when you see ST segment depression anywhere outside of AVR and V1, if you see ST segment depression in any of the other leads, you ought to really be thinking about STEMI and not pericarditis. So this is a really concerning 12-lead EKG. Forget the PR segments. We've talked about that before also. You can see PR depression in various conditions. PR segment depression is not pathognomonic for pericarditis. PR segment depression can be seen in STEMI. And when you see ST depression, when you see that RT phenomenon, when you see that straightening on the initial part of the T wave, you've got to really worry about ACS. So let's move forward. This sure as heck looks like an acute anterolateral STEMI. So Lakshay went ahead and he got the cardiologist involved. The patient went up to the cath lab, and this 25-year-old guy with practically no cardiac risk factors, had an acute LAD occlusion. Fortunately, he had a good outcome. So kudos to Lakshay for that pickup. It could have been very easy to just discharge this guy without even getting a 12-lead EKG and just calling it musculoskeletal. And he told me that the main reason he got the 12-lead EKG was because of the vomiting, which didn't seem to make sense. So great pickup. Well, here's another relatively young patient that Lakshay saw. 24-year-old guy comes in with intermittent right-sided chest pain and vomiting over the past 6 hours. And it all started after he finished a marathon. You figure anybody who can run a marathon has to be in pretty darn good shape. Physically, at least. I don't know about mentally, but physically. I've got some colleagues that love to run marathons, and the majority of them always tell me that it's the worst 2 or 3 hours of their life, and yet they keep going out and doing it over and over. I'm sure many of you out there run marathons, and good for you. I love to run. I've been running for, 30 years now, but I've only tried to do a marathon once, and this is pretty much what I look like towards the end of that marathon, so I don't plan to do that again. And, the other interesting thing about marathons that I'd like to remind my colleagues about is that the concept, the term marathon, comes from this ancient Greek legend from 490 BC. There was a runner courier by the name, I think I'm pronouncing this right, of Phidippides, who ran from the battlefield at Marathon all the way back to Athens to announced to everybody that the Greeks had beaten the Persians on the battlefield at Marathon, and this was about a 25-mile or 40-kilometer journey. And the legend has it that upon arrival in Athens, and he announced to all the people there that the Greeks had won, he immediately then collapsed and died. And so this is an artist's rendition of his arrival and then announcement that the Greeks had won. And then just to add insult to injury, not only did he die, but apparently he also lost all of his clothes during that run from Marathon all the way back to Athens. And some of us have a slightly different theory about this run. And some of us believe that when he ran from Marathon back to Athens, it wasn't because he wanted to announce the victory, but he was actually running back to Athens to go shopping for new clothes. I'm not really sure which is the true story. I mean, looking at his feet actually look pretty good, so maybe he at the very least had some pretty good Nikes or some other good running shoes along the way. But gosh, why in the world did this guy lose his clothes along the way? So anyway, let's get back to the EKG topic at hand. So this 24-year-old guy, he's run a marathon. He's obviously in really great shape to be running a marathon. And now he's got this right-sided chest pain, vomiting for 6 hours. He's probably exhausted. Heat stroke, heat exhaustion, you start thinking about. He does have a family history of cardiac disease, but really no other risk factors. He's not a smoker. No medications, alcohol. His vital signs look pretty good. The rest of his exam is pretty good also. And so he's presumed to have dehydration. So Lakshay decided to get a 12-lead ECG, maybe to just check for electrolyte abnormalities. Maybe he's hypokalemic or hypomagnesiemic. Maybe he's got a really long QT interval. Maybe he's got renal failure from dehydration and he's got signs of hyperkalemia. So anyway, here's the 12-lead EKG, and holy smokes, take a look at this thing. This guy who just finished running a marathon sure as heck looks like he's having a big anterolateral wall STEMI. 24 years old, just finished a marathon. So there's some of our concerning features once again. You take a look at this straightening on the top of that QRS complex, or on the top of that T wave. It's very straight. There again, it's very straight. There again, the initial part of the T wave is very straight. And when you've got that straightened appearance, then you've got to worry about cardiac ischemia. Well, there's a few other things. He's got Q waves in lead V1. He's got a Q wave in V2. So probably he's already developed a significant infarction, but the fact that he's got ST elevation means he's got ongoing ischemia. He's also got ST depression in a couple of his inferior leads. So this is kind of a no-brainer STEMI, right? Well, actually, couldn't believe it. It was 1:05 in the morning. He said, let me repeat this and maybe it'll go away. Well, it didn't go away by 1:25. It didn't go away by 1:51. And along this period of time, he's been calling cardiology, trying to convince them to take this patient up to the cath lab. Unfortunately, at this hour, they're not able to do the cath. So the patient ended up getting tenecteplase. And thrombolytics are a great option when you don't have emergent cath. Unfortunately, thrombolytics tend to fail in about a third of cases, and this was one of those cases. Thrombolytics didn't work, so then the patient ended up going for rescue angioplasty, and sure enough, this 24-year-old guy who's out there running marathons had a 90% distal LAD lesion and 80% proximal LAD lesion. Thankfully, this guy was stented and did not end up like that Phidippides who died after running that marathon. And I believe this patient, this 24-year-old patient, also was better clothed than Phidippides. All right. So anyway, we've talked about the EKGs. I did want to go on a little bit of a tangent to talk about age and risk factors here for acute STEMI, because a lot of the missed STEMIs that I hear about and I see are relatively young patients. Oftentimes they don't even get 12-lead EKGs, and I think it's because we've all been brought up with this notion that you've got to be at least 55, maybe at least 45, I learned 55 in medical school, to have a significant risk for acute cardiac disease. So again, in medical school and in residency, I was taught 55, and over the years I've lowered it to 45, and then maybe I lowered it to 35, and I don't know what the lower age limit is, at which point you're at risk for cardiac disease. In fact, young patients do have MIs, and these are just some U.S. statistics, but I'm sure they play out in every country out there. Over 100,000 MIs occur every year in relatively young patients. These are patients that I would have thought are too young to have MIs, certainly down in the 20s and 30s, and only a minority of these are related to patients that are on cocaine. So you can't just assume that all of these are cocaine-related MIs. Well, this concept of young patients having MIs is not new. In fact, pathologists have known this fact for many, many years. Back in the 1950s and 1960s, there were soldiers that were killed in the Korean and Vietnam Wars. Now think about this for a second. These are soldiers, these are young men who are incredibly healthy, incredibly physically fit. They're running around the battlefield with 50-pound backpacks on their back. They are incredibly physically fit. And these soldiers that were killed in combat had autopsies, and the pathologists back in the 50s and 60s described significant atherosclerotic abnormalities in these relatively young, healthy men. And what do they always say about pathologists, right? Pathologists know everything, just a day too late, right? So the pathologists have known about this for many, many years. Back in 1993, a study was published in the Journal of the American College of Cardiology, which talked a little bit about this also. They did autopsies on 111 patients that were killed in inner city gang type of related violence. So these are not young people that are dying of clear heart attacks. These are young patients that are dying due to violence or accidents. They did autopsies on these patients. Take a look. Average age was 26 years old. And what did they find in these young people? Well, 3/4 of these patients had significant atherosclerotic disease, 20% had multivessel disease, 9% had more than 75% narrowing in at least one vessel. Average age, 26 years old. So this is not new information. And in fact, this is 20 years ago. And I have to say that diets have gotten worse and worse and worse over the past 20 years. Here's another study to really hammer home this point. This is from 2005, so almost 10 years ago. 1,000 patients, relatively young patients, presented with chest pain in this study. Cocaine users were excluded. They had a really good 30-day follow-up, and they followed up these 1,000 young people, and what they found was 5% ended up ruling in for ACS, 2% ended up either dying, having MIs, or needed emergent invasive therapy. Again, these patients were under the age of 40. A lot of these patients were in their 20s. So the concept of atherosclerosis in young patients is very, very true. And we've all been taught a myth that if you're really young, you're not going to have an MI, and that's not totally true. It may be rare, but it happens. And things are only getting worse. A lot of the pediatric cardiologists are predicting that we're going to be seeing more and more acute MIs in teenagers in the coming years because of how awful Western diets have become. And you and I practicing in the emergency department see this all the time. Pediatric obesity rates are on the rise significantly. And in fact, here's another astounding statistic that I pulled up off the internet. This is from June 2010. In 2009, pediatricians in the U.S. wrote for 2.8 million prescriptions for drugs to lower cholesterol in kids. 2.3 million prescriptions for statins in kids. Is there any doubt that in the coming years we're going to be seeing more and more and more young people, adolescents, teenagers coming in with true atherosclerosis-related MIs? Please, if you've been taught that you need to be 55 or 45 or whatever it is to be at risk for atherosclerosis, just get rid of that myth. Times are changing, and you ought to be basing your decision not on age, but on the history of present illness. All right. Okay, so let's bring this home. Let's talk about some of the take-home points from today's slightly longer session. Pericarditis versus STEMI. We're going to get a lot more into this maybe next week, because there was a really nice article that was published in New England Journal of Medicine that talked about pericarditis. So we're going to go into that article in a little bit more length. But just for this week, a couple quick take-home points about pericarditis versus STEMI. Remember that PR depression and PR elevation in AVR is not pathognomonic for pericarditis. You can and you will see that in true STEMIs. But if you see ST depression, that's a great pearl to keep in mind. If you see ST depression, ignoring AVR and V1, ST depression and any other leads, you've got to think STEMI. Pericarditis should not do that. Other findings that are suggestive of acute coronary syndrome: disproportionate T-wave size. You know what? I even forgot to even talk about that. Let's go back for just a second to take a look at those initial 12-lead EKGs that we talked about. Take a look at how small this QRS complex is and how big that T-wave is in comparison to the QRS complex. And this is another nice example. You've got a relatively small QRS complex and a gigantic T-wave in there. Pericarditis doesn't do that. That is a STEMI until proven otherwise. So when you see that disproportionate size T-wave in comparison to the QRS complex, please think about acute coronary syndrome and STEMI. And also, we did mention this, when you see straightening on that initial portion of the T-wave, then that straightening ought to make you worry about acute coronary syndrome and nothing else. All right? Cardiac disease does occur in young patients, and we're going to be seeing it show up in the emergency department more and more and more. Focus on the patient's presentation and not the patient's age. If you focus on the patient's age, you will be misled, because MIs and ACS are occurring more and more often in patients that are much younger than we were ever taught. All right? A couple other take-home points. Torso pain plus vomiting. If you don't have a good reason for that vomiting itself should prompt a 12-lead EKG. After all, what is the EKG or ECG? It's a piece of paper and ink. It costs practically nothing. So just get the ECG. I'm not saying you got to send enzymes on all these patients. I'm not saying you activate the cath lab. I'm just saying get a 12-lead ECG, as Lakshay did in these cases. Both of these patients, by the way, were vomiting, and that was a prompt to him to get the ECGs. And we're going to say this over and over on these video casts because this is really important. The literature has shown that there are 4 factors in chest pain patients that are the greatest predictors that your patient will end up ruling in for ACS. Chest pain plus vomiting, chest pain plus diaphoresis, chest pain that radiates, chest pain that worsens with exertion. If your patient has any of these 4 factors, it means you really need to worry. You need to make sure you always ask the patient about those 4 factors and make sure that they are documented on your chart if they're present or absent. And that's going to be very helpful clinically in terms of distinguishing whether your chest pain patient has ACS or not. All right. Well, that's it for this week's case. Once again, my thanks to Lakshay Chanana for sending these 2 cases, and I hope that was helpful. I look forward to talking to all of you next week. Bye for now.